The patient today is CJ, a 66-year-old male who has a medical history of just recently getting out of the hospital after an open heart surgery. He has a history of emphysema as well as a cholecystectomy. Um, and he comes to us today in cardiac rehab with some significant weight loss that was unexpected. So looking at CJ's nutrition related history, he's had a pretty poor intake. While he was in the hospital, he was NPO for roughly 2 weeks. Um, his only form of nourishment was a D5 lactated Ringer solution, which, while he was intubated, ran at 125 milliliters an hour and then was reduced to 75 milliliters an hour, which is not a significant amount of calories for this patient. Once he was extubated, they started him on clear liquids and worked him up to fulls and then a mechanical soft 2-gram sodium diet. He indicates that he's been afraid of eating a little bit. Before his surgery, he was very nervous and fearful, so he really didn't have any appetite. So even before he was NPO, he wasn't eating well. And since the surgery, when he was finally put on clear or solid foods, he was fearful to start eating, so the intake, even at the beginning of when he could start eating solid foods, was pretty minimal because he's a little bit afraid at that point with his chest pain after the surgery, the incision points there, and combined with his fatigue, he just really hasn't been eating very well. So we've had a minimal intake recorded by the nursing staff before he was discharged, and there's no indication that he was eating even one meal a significant amount from the nursing staff. The patient also reports that he has no appetite and he has a very bad taste in his mouth, so he hasn't really felt like eating there. And he's also had a lot of these medical stressors from the surgery and then just all the anticipation leading up to it and kind of this fear of starting to eat after that. So these are some things we're going to have to work on with him as we go through the assessment here. So just reviewing his anthropometrics, he's 66 years old. He's male. His height is 5'9". His current weight is 160 pounds. Before the surgery, he was 178 pounds, and 1 month from today, he was 185 pounds. So he's had a 25-pound weight loss in the past month, which is significant. Prior to surgery, he was actually considered overweight, but now his BMI falls at 23.63, which is considered within normal limits. So when we're looking at his assessment later, we're not really going to want to have him gain all that weight back, but just kind of maintain it. So just looking at his labs, these aren't really the normal labs. These are more indicators of his lung function. And as you can see, it was taken pre-op, while he was intubated, and after he was extubated, just to kind of see, how is he doing as far as his emphysema goes. So just to touch on what emphysema is before I get into the labs, it's a lung disease that's usually caused or closely related to smoking. It can also be caused by constant exposure to other toxins in the air or pollutants, and it can also be caused by a genetic defect of the protein that's created in the sebum for the alveoli. So in his case, it was from the smoking, most likely. He does have a history of smoking. And what happens is that inhalation of the pollutants damages the capillaries inside the alveoli and causes them to stop secreting a sufficient amount of sebum to keep the alveoli flexible, so what they can react to inhaling and exhaling. So what happens is they kind of stretch out and they stay stretched out. And that's part of the reason the body's compensating and trying to get as much air in there as possible, because the surface area for exchange is not only, it's very stiff, but also because that sebum isn't there to create like a reactant surface, there's not a lot of exchange going on between carbon dioxide and the oxygen. They're not exchanging along that wall. So it gets stretched out, and then you can also see a lot of people get what's called a barrel chest, or their chest comes out and gets more rounded looking because they're constantly over inhaling, so it kind of stretches the rib cage out to compensate for that lack of surface area to have the oxygen carbon dioxide exchange. And also you'll see the diaphragm, which is usually kind of arched shape, if you see it in an x-ray, it's flattened out too to kind of help stretch everything out so you can get as much surface area for that interaction, that chemical reaction and exchange of gases as possible. So looking back at his labs, you can see that his exchanges don't look very good. His O2 saturation, or his pressure in his lungs, is very low. It's at 50. It should be up around like 100. Um, his bicarbonate's high, as well as the pressure in his lungs that has CO2 in it, and that's because it's not exchanging on the surface area of the alveoli. Um, and then just kind of a note here, you can see when he was intubated, his O2 was up in the normal range, but his bicarbonate was high, which made him a little acidotic, and his PO, or the pressure of the carbon dioxide in the lungs was high as well, because it can't make that exchange because it's lacking that sebum to moisten the inside of the alveoli. So moving on, looking at his relevant medical diagnoses, as I said earlier, he had the open heart surgery. Before that, he had a catheter placement, and that's where they found several blockages in his coronary artery and around his heart. So, although it wasn't indicated here, it's kind of assumed he had some sort of bypass or something to either clean out his arteries, but in either case, they had to open him up completely to get to his heart and fix that. So that was about 3 weeks ago. He had to have a chest tube placement as well. He's been short of breath, and he does have hypercapnia, which is increased levels of carbon dioxide in the blood. Currently, he's just on the Combivalent inhaler, which is used just to kind of combat that asthmatic feeling, the wheezing, open things up a little bit so he can get that exchange better. And that can cause dry mouth, which could be part of the reason he's having that bad taste in his mouth, and that might be something we work with him on, maybe get some sort of mouth moisturizer that he can use, like Biotine or something like that, so he doesn't have that nasty dry mouth, and we'll have to figure out that could be causing that metallic taste as well. So as I mentioned, he has emphysema and the cholecystectomy, which is the removal of the gallbladder. Looking at his needs, I estimated it using the Mifflin-St. Jean equation with an activity factor of 1.4. I'm just assuming that because he's short of breath a lot and very fatigued, he's really not going to be moving around a lot. So that gave me about 1,900 calories a day. I used 1.5 grams per kilogram of protein for repletion, and that's also recommended for COPD, which gives us about 110 grams of protein a day, as well as fluid is going to be around the normal, which is 30 milliliters per kilogram, and I said that gives us about 2.1 liters a day, and we really want to keep it to that 2.1 because any sort of overhydration can put pressure back on the heart and on the lungs if he's getting any sort of edema from that as well. So his current diet order, and this is from the hospital, he's been discharged, but this is what he was on when he left. Mechanical soft 2 grams sodium restriction. He supposedly feeds independently. There isn't anything to indicate otherwise. He doesn't have any chewing or swallowing difficulties, and his intake was reported to be minimal by the nursing staff. So moving on to his nutrition diagnosis, the first thing that popped up to me is he's malnourished. He hasn't eaten in about 2 weeks at least. Excuse me. And before that, and then for the following week, it seems like his intake's been really minimal. So malnutrition related to suboptimal intake for 3 to 4 weeks due to his acute medical complications, as evidenced by his 25-pound weight loss in a month, which is about 13.5% body mass lost. And we know that because he hasn't been eating, he's losing his lean body mass as well. Nursing reported minimal intake. The intake prior to discharge was indicated to be poor, so we can kind of assume it hasn't really gotten better. He indicates he's had nausea and bloating with his meals, so he still doesn't really feel like eating because he's got that bad taste in his mouth, and he feels bloated and nauseous after eating. And just his stressors as well, that he was afraid to eat, so that could be part of what's causing his malnutrition. So my recommendations for his nutrition prescription were to go with a 2,000 calorie diet, With the 2-gram sodium restriction and moderate carbohydrates, because he does have that high bicarbonate in his blood, we don't want to exacerbate that anymore and make him have to try and exchange that out by giving him a lot of carbohydrates. High protein, which is just anything over 80 grams, and he certainly does need high protein given his lean body mass loss and his just energy expenditure to breathe. We also want to kind of keep a low saturated fat, keeping in mind his heart health. He's just had an open heart surgery, but we don't want to really limit all fats because it's a great source of just calories in his diet. So we're really just going to focus on saturated fat in this situation. And I want to say give him a supplement too, because it seems like he's having a hard time eating, and I feel like he'd have a hard time preparing food as well. So we're going to try a boost or ensure supplement 2 times a day, just kind of in between meals, maybe as a snack or counting as one of his 5 to 6 meals. Because at this point I can't see him sitting down and eating 5 to 6 meals himself. I'm also assuming too that he lives alone, and with his increased fatigue, it's unlikely he's going to sit down and make 5 to 6 meals for himself. So we're going to work on that too with the education and having snacks and things like that available. So his food nutrient delivery is of course meals and snacks. We're not going to take those away, but I do want to add the medical food supplement, which is either the boost or ensure shake. And of course, I'd talk to the patient too about whether they were agreeable to trying something like that. As far as education goes, we want to educate him on the recommended modifications. So, limiting the saturated fat, making sure he's getting a lot of calories, a lot of protein, getting maybe a little bit extra with that supplement too, and having those small frequent meals so that he's not getting that bloated feeling so easily. If they're small, it won't feel like there's so much pushing against the walls of his diaphragm and his stomach. And we also want a little bit of skill development as far as what are salt containing foods and what foods are nutrient dense, so he can have a small meal and still get a lot out of it as far as calories, protein, and some of his micronutrients as well. As far as counseling goes, we want to give him a little bit of self-monitoring as far as, he's eating to improve his appetite and also to maintain his weight, so those are things that he can monitor himself at home. Some problem solving, flavoring foods that are really pungent so it kind of overwhelms that metallic or whatever bitter taste is in his mouth without using salt. And some goal setting as far as making his environment friendly to his disease state so he doesn't have to work so hard to make foods, or maybe finding someone that can be a support for him at home, setting goals to see, okay, who can help me, what days, and how can I support myself as well. And for coordination of care, for him, because he potentially lives alone, some sort of food assistance program would be helpful because he's going to be fatigued and short of breath so easily. So maybe a home delivery program, Meals on Wheels, or even if he can get out of the house and go to a congregate meal or something like that. I know he's not that old yet, but that's what these programs are for, to help people that are having issues taking care of themselves, even if it's just temporary until he can get some of his strength back. So as far as his goals, we want to see some weight maintenance, his intake to meet his estimated needs, and to have GI tolerance at meals. As far as that goes, we want to see his weight stay within plus or minus 3% every month of his current body weight. We don't want that to change anymore, and if we're seeing him more frequently, maybe weekly for a little while until we've set him up with his skill set so he can take care of himself, we want to see his weight stay within a pound every week of his current body weight. We don't want it to go up and down drastically. As far as his intake, I'm hoping that he'll keep a food journal, or even from his recall, talking to him during counseling sessions or whatever. I want to see him, making the decisions to eat more frequently, small meals, and we want him to have some GI tolerance as well, so he's not feeling that bloating. Things like separating his liquids from his meals will all be helpful for this patient as well. So, and then again, see that he's snacking and getting some more food in there. And this is something just to keep in mind because he's an older patient. He may or may not increase his intake that drastically, but we're hoping that with some different sessions, he'll slowly get to where he needs to be. Those are my assumptions.